Hey, this is Bert Bunnell. I'm going to talk to you about our 7 steps to success. This is our general guide to optimizing the jet that we've developed over 25 years of clinical use and treating about 100,000 babies. And we developed this guide from feedback from people like you. So these steps may change in the future, but for now, this is what we think is your best chance of optimizing the jet. Our overall goal here is to provide lung protective ventilation. And by that I mean we want to get the alveoli open, we want to keep them open, and then we want to ventilate as gently as possible. And we think the jet is really the ultimate way of doing this. Now the first step to success is actually a planning step. Before you start using the jet, it's really helpful to get together with all your colleagues and talk about when are you going to use the jet. You've got lots of possibilities. Now, if people are uncomfortable with the jet, they're going to wait until everything else in the hospital's failed before they bring it out of the closet. If people are comfortable with the oscillator, they would naturally wait until that isn't working as well as they would like. If people don't have a comfort level with any high-frequency ventilator, they're going to do the best they can with a conventional ventilator before they start the jet. What we'd like to encourage people to do is to think about using the jet as soon as nasal CPAP isn't working anymore. But we know we're very biased, and it's going to take most people a long time before they get to that point. So we like to share what Utah Valley Medical Center does. Now, Utah Valley is the national training site for Sensormedics and their 3100A oscillator. But they've been using the jet since about 1985, and in 1990 they were pretty comfortable in using the jet as their first ventilator for any baby that developed an air leak, excessive secretions, or when they had to ventilate a patient with cardiac output problems. Their fourth criteria was to use the jet whenever the oscillator wasn't working for him anymore. They call that when the oscillator fails, but it's not really a matter of failing. I think it's when the lung disease morphs into something more heterogeneous, like chronic lung disease. The second step to success is where we begin to talk about the ventilator settings. And the first thing you should consider is what rate should you start with. We like to recommend using something about 10 times faster than what you would do if you just kept the baby on a conventional mechanical ventilator. For example, if you're treating a little tiny preemie with just RDS, you can go about as fast as you want. Because the jet uses passive exhalation, but if you're treating a tiny baby, you're going to be using very small tidal volumes, and the lungs are going to be stiff enough that you'll get that gas back very readily. The maximum frequency on the jet is just 660 breaths a minute, so if you're comfortable treating that baby with 66 breaths a minute, you can go as fast as you want. But if you're treating any other kind of baby, chances are you're going to need a longer time for exhalation, and that's what you get when you slow the jet down. This is especially helpful in treating patients that have any kind of airway obstruction problem, and when you want to encourage them to do more spontaneous breathing. If you look at the IDE ratios at the various rates, and you think about the kinds of patients that you would choose to treat with the various rates, you can see the relationship between the IDE ratio and the rate and what's wrong with the baby. For example, we've had a lot of anecdotal success in treating older premature babies with chronic lung disease. Here, using a rate of 240 breaths a minute gives you an IDE ratio of 1 to 12. And we found that this is very helpful in treating pulmonary hyperinflation. If you think about BPD and what happens when a baby's lungs begin to get larger and larger the older they get, and you reach the point where there's all kinds of gas trapped in the interstitial space, and you get an X-ray and you see that reflected in the X-ray, you have to ask yourself, where is the gas trapped and how am I going to get it out of there? Most people, when they look at this kind of X-ray, think, oh, geez, I better lower the mean airway pressure. So they might lower the PEEP. Well, that's seldom helpful. And the next time you give a big breath, it could actually make matters worse because the airways are going to be smaller on exhalation, and those big breaths will get trapped even more than they did previously. What we found to be most helpful is to get rid of all the big breaths, keep the PEEP moderately high, maybe 7, 8, 9, and use the lowest possible jet rate. That gives you that ID ratio of 1 to 12, which really improves your chances of the gas in the interstitial space being able to diffuse across those membranes into the alveoli or airways where they can leave. Okay, the third step to success is all about mean airway pressure. Here, the approach is very similar to what we've learned to do with a high-frequency oscillator. We need to get the lungs open and keep them open. So it's the same approach with the jet. Now, we use the jet side by side with the conventional ventilator, and the conventional ventilator can be very helpful. But before you start, you want to monitor what you're doing with that conventional ventilator, so we make sure that if there's any differences in calibration, we can take that into account. And you want to focus primarily on how much mean airway pressure is being used with the conventional ventilator before you switch to the jet, and make a commitment to not let that mean airway pressure fall. And you're going to control that with the conventional ventilator's PEEP valve. So as you consider switching from a conventional ventilator to the jet, write down the mean airway pressure you're using before you switch to the jet, and when you make the switch, you'll have to raise the PEEP as necessary to keep that mean airway pressure constant. That usually requires an increase in PEEP of about 2 centimeters of water. Now, this is a general recommendation, even for babies with air leaks. But of course, it may not be the right thing to do if the baby's got a cardiac output problem. In that case, you need to compromise, use a lower PEEP, and keep the lungs open with an occasional big breath from the conventional ventilator. Now, if you're switching a baby from the oscillator to the jet, you can also monitor what you're doing before you make the switch. The people at Duke University have proven that the jet is an accurate monitor of high-frequency oscillation. And here, the approach will be trying to use that information to make a reasonable choice as to how to begin when you make that transition. In this case, you'll probably go down in the mean airway pressure by about 2 centimeters of water, but at least you have some information about what the PIP and the PEEP are before you make that transition. Now finally, you can monitor manual ventilation with the jet in the standby mode. And this can be really helpful when you've got one of those babies that you can only keep alive while you're handbagging. Every time you try to go back to any other kind of ventilator, it just doesn't work as well. We had a wonderful case study presented at the last SPR meeting in the AARC, the baby again at Duke University, where they had exactly that experience. This 600-gram baby had pulmonary hemorrhage, and no matter what they did with an oscillator, a jet, or a conventional ventilator, they just couldn't keep that baby alive. But while they were handbagging, they got perfectly good oxygen saturations. So they hooked up the jet in the standby mode and found that the pressures that they were using were just extraordinary. And when they switched the baby to the jet, reproducing that mean airway pressure using a PEEP at 20, they were successful. And they only had to leave the baby on those very high settings for about an hour. The bleeding stopped. Then they were able to wean that PEEP very quickly. And they actually sent home this 600-gram birth weight baby with no chronic lung disease. Quite an accomplishment. Okay, the fourth step to success is the most simple step. Here, we're going to control PCO2 using the same general approach we use with either the oscillator or conventional ventilator. On the jet, as with conventional ventilation, it's the PIP that creates the tidal volume, and the tidal volume is most important with high-frequency ventilation because of this exponent that shows up in the relationship for any high-frequency ventilator. Now, sometimes you have to use fairly high PIPs with the jet in order to get CO2 down to where you want it. And you have to remind yourself that the tidal volumes from the jet are much, much smaller than those used with a conventional ventilator. So don't think of a PIP of 40 or 50 on the jet as being anywhere near as hazardous as a comparable PIP on a conventional ventilator. And it'll be by far your easiest way to get that CO2 down. The fifth step to success is how to find and set optimal PEEP. Now here's where we can really use the conventional ventilator to our greatest advantage. The general rule is that the big breaths from the conventional ventilator recruit alveoli and PEEP stabilizes them. But we want to get rid of those big breaths every chance we get. So we want to be pushing the conventional ventilator towards the CPAP mode whenever oxygen saturation is adequate. And anytime saturation is inadequate, when you drop that IMV rate, it means your mean airway pressure is too low and you need to raise your PEEP. It doesn't mean that you need to keep giving some what we call background conventional ventilation. So here's the general approach. You might be starting out on a baby with a PEEP of 5 and ventilating conventionally, opening up some alveoli and allowing them to collapse with every breath. And you want to switch to the jet. So you focus on that mean airway pressure that you're using now, which in this case is 9. And when you switch to the jet, you want to reproduce that mean airway pressure by increasing the PEEP, which usually requires about 2 additional centimeters of water. But before you give up on your conventional ventilator, keep it running with 5 breaths a minute until you get the FiO2 adjusted and you get a constant oxygen saturation of about 90%. Then turn off those IMV breaths to test your PEEP. Does the saturation fall when you take away those last 5 breaths per minute? If it does, it means your PEEP is inadequate. You've got to increase your PEEP just a little bit more to really stabilize those alveoli and continue without needing the big breaths. Now you'll be providing the most gentle mechanical ventilation possible. The sixth step to success is how to stay on track. Here, servo pressure on the jet ventilator is very, very helpful. You also, of course, want to be using transcutaneous CO2 and pulse oximetry, and you need to be patient at times. Now, whenever the servo pressure is going up, it means you might need to wean to keep CO2 in the proper range. And if servo pressure is going down, it may mean you need to suction, you need to reposition the ET tube, or any number of other things. And if you're ever in doubt, this is the perfect time to call us on the hotline, where we're available 24 hours around the clock. This last step, the seventh step, is to stay the course. You want to take every baby who's been doing well on the jet all the way to nasal CPAP to extubate the baby. If you try to go back to conventional ventilation, you may just recreate the problem that led you to go to the jet in the first place, and that's not going to be doing your patient any favors. The way to wean the jet is really straightforward. You get rid of those things that are most hazardous first, the big breaths, the high FiO2s, then you can start worrying about weaning the PEEP and the mean airway pressure. As ventilation improves, you reduce the jet PIP first, then the jet rate to encourage more spontaneous breathing. Remember, as you lower the jet rate, you'll be allowing more and more time for spontaneous breathing. And it's finally time to extubate when all the pressures have been weaned to low levels. You've got a low FiO2, and at that point you just pull the endotracheal tube, establish nasal CPAP using a setting that's close to whatever mean airway pressure you were on last with the jet, and hopefully you'll be finished on that patient with mechanical ventilation. So in conclusion, if you plan ahead and implement the jet using these 7 principles of lung protective ventilation, you should be successful. Good luck.